Yep. So when it's red, it's off. It's on. When it's red, it's on.
A quorum being present, the Subcommittee on Health, Employment, Labor, and Pensions will come to order. Good morning, and welcome to today's subcommittee hearing. I'd like to thank our panel of witnesses and our members for joining today's important discussion on the Department of Labor's proposed rule on association health plans, or AHPs, and how we can make affordable health care options a reality for more working Americans. The timing of this particular hearing is appropriate as this week marks 8 years since the passage of the Affordable Care Act. Since Obamacare became the law of the land, America's small businesses have struggled to dig themselves out from under the law's crushing weight. Since 2008, the share of small businesses with fewer than 10 employees offering health coverage has dropped by a shocking 36%. Leaving working Americans with fewer health care options or no coverage at all. It's estimated that 300,000 small businesses' jobs have been eliminated because of the Affordable Care Act, and 10,000 small businesses nationwide have been forced to close their doors. The financial burden this law has placed on Main Street businesses has been debilitating, with its costs and mandates amounting to an estimated $19 billion in lost wages for small business employees. Time and again, those of us on this committee have heard from small business owners that one of their greatest concerns is the high cost of health insurance. America's job creators deserve better than the failing status quo of limited coverage options at sky-high prices. Instead, small businesses should be empowered to negotiate for the very best coverage at the very best prices on behalf of their employees, just as big businesses and labor unions do. In 2017, this committee favorably reported the House passed H.R. 1101, the Small Business Health Fairness Act, legislation I introduced with our colleague Representative Sam Johnson from Texas, Chairman of the Ways and Means Subcommittee on Social Security. This legislation would expand health care coverage and lower costs for workers by empowering small businesses to band together through association health plans and negotiate for lower costs on behalf of their employees. By granting small businesses the ability to join together through AHPs, small businesses would be able to strengthen their bargaining power in the health insurance market in order to secure health coverage options on par with that of larger companies and unions. In October of last year, President Trump issued an executive order directing the Department of Labor, Health and Human Services and the Treasury to use their regulatory authority to expand access to AHPs. In response to the President's directive, the Department of Labor proposed a rule in January to broaden the criteria for determining whether employers may join together in an employer group or association in order to form an AHP. Given the committee's longstanding interest and activities on AHPs, this recent action by Department of Labor presents an opportunity to examine the department's plan to expand small business access to affordable health care options and thereby decrease the number of uninsured individuals. Empowering small businesses to form AHPs is especially near and dear to my heart, and I'm pleased to see such strong progress on an issue that will directly benefit our nation's job creators and their employees. I look forward to hearing from our panel of witnesses and from other members of the subcommittee today as we examine this proposed rule and work to do right by America's small businesses. I now yield to our ranking member today, Ms. Blunt-Rochester, for opening remarks.
Thank you, Chairman Walberg. Today's hearing comes just days before the 8th anniversary of the Affordable Care Act, or the ACA, legislation that has helped 20 million people gain health coverage, including 38,000 Delawareans, and also expanded protections to millions more across the country who had pre-existing conditions. Over the past year, we have seen continual efforts by the administration and congressional Republicans to undermine that progress, including one of many failed attempts to repeal the law this past year. But with Congress's inability to pass legislation to repeal and replace the ACA, the administration has been unyielding in its attacks, refusing to faithfully implement the law of the land. The Department of Labor's proposed rule to expand association health plans is another attempt to sabotage Americans' access to comprehensive, affordable health coverage. Under current law, health insurance coverage offered through a group or association to individuals or small employers is generally treated like individual or small group coverage. This means businesses and individuals with health insurance through associations have the same protections as people in state-regulated individual and small group markets. This includes coverage of essential health benefits, including maternity care and substance abuse disorder treatment, and prohibitions against being charged more based on gender. Under current Department of Labor sub-regulatory guidance, there are strict criteria under which employer association health coverage is treated as a single large group ERISA covered plan and thus exempt from adhering to these rules. The use of this strict criteria in this way helps protect against cherry picking only healthy consumers for the sole purpose of providing health coverage that has nothing to do with the actual employment. The department's proposed rule would weaken the criteria for associations to be able to purchase insurance exempt from certain federal consumer protections. Simply put, the rule takes us backwards. While the rule's proponents claim it will help small businesses, in fact, this rule could limit access to comprehensive coverage for many small businesses and their workers, increase costs, and threaten access to those with pre-existing conditions. Troublingly, it also has the potential to leave small businesses and their workers on the hook for millions of unpaid medical bills. First, this proposed rule would limit access to comprehensive health coverage. Without guaranteed coverage for essential health benefits such as maternity care, mental health treatment, and substance use treatment, this means people may be left with skimpy and inadequate coverage that neither gives them access to the care they need nor offers adequate financial protection against serious medical conditions. Second, the proposed rule will increase cost and threaten coverage for people with pre-existing conditions. As healthier and lower-cost consumers get cheap plans with skimpy benefits that may not meet their health needs, older or sicker consumers would be left behind in the traditional market with skyrocketing costs, making it difficult to obtain coverage. Third, the proposed rule could potentially leave small businesses and their workers on the hook for millions in unpaid medical bills. As we have seen through testimony in previous hearings on this topic, association health plans have a long history of insolvencies, scams, and fraud. Between 2000 and 2002, scams impacted more than 200,000 people and left more than $252 million in unpaid medical bills. As we all know, those who do not learn from history are doomed to repeat it. The Coalition Against Insurance Fraud stated that under the rule, quote, small businesses and their workers will face a huge and intolerable risk of fraud, end quote. It seems to me that a common sense approach to supporting small businesses and helping them thrive would not and should include needlessly exposing them to the insolvencies, scams, and fraud that could force them to shutter their doors for good. Taken together, This proposed rule would leave some with cheaper coverage that fails to meet their basic health needs and leave everyone else with higher costs. While the Department of Labor is not represented on this panel today, the gaps in the proposed rule's justification and analysis provided by the department are very troublesome. Members of Congress and the general public would benefit from an opportunity to hear from the department. I will note that members of this committee have requested more information from the department on its analysis, to no avail. As pointed out in a comment letter submitted by 17 state attorneys general, including Matt Dent, Attorney General of my home state of Delaware, the rule would reverse critical consumer protections and unduly expand access to AHPs without sufficient justification or consideration of the consequences. Rather than continuing to this campaign of interference, I hope the administration and my colleagues will join with Democrats to find ways to strengthen the ACA and increase access to affordable, comprehensive health coverage. I thank the witnesses for joining us here today, and I yield back.
Thank the gentlelady. Pursuant to Committee Rule 7C, all members will be permitted to submit written statements to be included in the permanent hearing record. And without objection, the hearing record will remain open for 14 days to allow such statements and other extraneous material referenced during the hearing to be submitted for the official hearing record. It's now my pleasure to introduce our distinguished witnesses. Ms. Catherine Munson is the CEO and president of Fast Signs International Incorporated in Carrollton, Texas, and is testifying on behalf of the International Franchise Association. Mr. Michael McGrew is the CEO of McGrew Real Estate in Lawrence, Kansas, and is testifying on behalf of the National Association of Realtors. Mr. John Runsmeyer is founder and CEO of the Small Business Majority here in Washington, D.C. Mr. Christopher Condalucci, forgive me for that, is principal and sole shareholder of CC Law and Policy PLC here in Washington, D.C. I welcome each of you. I'll now ask our witnesses to raise your right hand. Do you solemnly swear to affirm that the testimony you are about to give will be the truth, the whole truth, and nothing but the truth? Let the record reflect the witnesses answered all in the affirmative. Before I recognize you to provide your testimony, let me briefly explain the lighting system. It's just like the rules of the road. Green, keep on going when you're 5 minutes. Hits yellow, you have a minute to wrap up. And when it hits red, please wrap up as quickly as you can. We will try to do the same as members ask questions as well. And so now, welcome, Ms. Munson. We recognize you for your 5 minutes of testimony.
Thank you very much. Chairwoman Fox, it's great to see you again. Chairman Walberg, great meeting you. Ranking Member Blount-Rochester, thank you so much for your kind words last week at the Minority and Franchising event, and I hope you met Fast Signs franchisee Howard James at the event. He was one of the speakers. And members of the committee, my name is Catherine Monson. I'm here on behalf of Fast Signs International, our 604 Fast Signs franchisees in the U.S., with others in other countries, and another 37 franchisees in the U.S. about to open their businesses. I'm here also with the International Franchise Association. I'm the second vice chair of that association, and we represent over 733,000 franchise businesses employing 7.6 million employees in the U.S. today. I have made my career in franchising. I love franchising. I've seen it build wealth for families, create jobs and opportunities. It is an amazing ladder of opportunities for women, minorities, and immigrants. And our recent IFA minority study shows a 50% increase in minority ownership of franchises since 2007, up to 30.6%, something we're very, very proud about. For each of you, there are about 2,000 franchise businesses in each of your districts, and franchising is perfectly built for association health plans. We use economies of scale to help businesses deliver affordable products and services. I guarantee you the Dunkin' Donut franchisee in your territory, in your district, pays less for flour and eggs and coffee than an independent donut business does, and the Fast Signs in your district pays less for printers and inks and substrates. and we want to bring that same negotiating power and economies of scale to association health plans. Small businesses' health plans are great. If I talk about Fast Signs franchisees, the average has 5 to 7 employees. In that very difficult 10 or fewer employee small business healthcare market where they have no negotiating power. They can go to Blue Cross Blue Shield and ask for better rates, and at 10 employees or less, they don't get it. They come back to their employees can't afford their part of it. Some employees are on their spouse's or parents' plan. It's very, very challenging. IFA recently surveyed its franchisee members, and 65% do not provide health care coverage. 92% of that group do not provide it because they just can't handle the cost burden, but 100% would look for health coverage and provide it if they could get it through an association health plan. The IFA strongly supports the administration's rule. We know we can pool resources, and here's the key. It's getting quality health care. It is not about skinny plans. My franchisees and other franchisees want to have the best labor available. They want to have the best employees. It's about competing with large companies for the best employees. Skinny plans are not going to be considered at all. Under the proposed rule, businesses can band together either by commonality of interest or commonality of region. And the broader the definition of commonality interest, the better. The larger the pool, the lower the prices, the better quality, full coverage health care. Franchises know how to do this. We know how to pool resources. We know how to negotiate with vendors, bringing across, if we will, think about the International Franchise Association, 7.6 million employees could be covered by quality, affordable health care. It's all about a level playing field. We want the same exemptions to be able to buy large group health insurance coverage as the labor unions have, as large companies have. The IFA is urging the department to look at franchising as a commonality of interest too, and the Federal Trade Commission definition and state laws provide for great guidelines here. We've also urged the Department of Labor to include a joint employer safe harbor, and this is really, really critical for franchising to get involved and to really get the maximum benefit out of association health plans. We support the adoption of safe harbor in the final rule so that we would not be deemed joint employers just because there was an association health plan. Without the safe harbor, we feel it's very unlikely that the benefits of this important health care policy will really take hold. And we're really thankful for the bipartisan coalition of members of Congress, including Chairman Walberg, who've echoed our request. In closing, I want to say thank you very much for having me here. The International Franchise Association and Fast Signs strongly support the administration's rule and urge swift implementation. Franchising can and will be a willing partner in the effort to expand access to affordable, quality health care. That's the key. It's not skinny plans, bringing more options to our very important working families. Thank you so much.
Thank you. I recognize Mr. McGrew for your 5 minutes of testimony.
Good morning, Chairman Walberg, Ranking Member Blunt-Rochester, and members of the subcommittee. Thank you for holding this hearing today and the opportunity to testify on behalf of the National Association of Realtors' 1.3 million members. My name is Mike McGrew. I'm a third-generation realtor and CEO of McGrew Real Estate, an independent real estate brokerage with 70 independent realtors and 14 salaried employees in Lawrence, Kansas. I'm the immediate past treasurer of the National Association of Realtors and a member of the Executive Committee, which establishes NAR's governing policies and oversees NAR's member benefits program. As a practicing realtor since 1982, I know firsthand how hard it is to find and keep health insurance when you're a sole proprietor and you have no employer coverage. I also know how hard it is to find affordable health coverage for your employees when you're the boss. The challenges facing the nation's small business and independent contractor community when searching for affordable health insurance continue to grow each year as costs rise and options diminish. The Department of Labor's proposed rulemaking seeks to make it possible for the self-employed and small employers to purchase health insurance through a trade association. Access to more health insurance options is key for realtors, a group that now purchases coverage primarily in the struggling individual markets. To understand the insurance challenges we face, it's important to know a bit about the structure of our industry. My company is a good example of a typical independent real estate firm. All of our agents are independent contractors. They have broad freedom to build their business as they choose under our state-mandated legal supervision responsibilities, and they value that independence. They have no limits on what they can earn, but they have no guaranteed paycheck. They wake up every morning unemployed and have to hunt for their next deal. While we provide health insurance to our salaried support staff, we do not provide health insurance to our independent agents. When real estate agents and brokers forego health insurance, the primary reason cited is cost, and it's this experience that has driven NAR to seek additional health insurance options for our membership. NAR has long supported legislation that would allow trade associations to create association health plans, including Chairman Wahlberg's Small Business Health Fairness Act. NAR also supports the Department of Labor's proposal that will provide more small businesses as well as independent contractors with access to an association health plan. It is essential that any final rule makes self-employed individuals with no employees or working owners eligible to participate in an AHP. It is also important to note that under the rule, association health plans would still be subject to consumer protections under the ACA, ERISA, and state benefit mandates. In fact, it would not be in NAR's interest to offer a benefit program that is not a quality product, because it would fail to attract members, and our demographics are much older in NAR. Additionally, since our surveys indicate that realtors' top priorities are affordability and access to preferred doctors, any association plan must achieve those goals as well. The association has questions about the rule, as it remains unclear how state regulation would impact association plans, especially those of national groups like NAR, whose members can be found in all 50 states. If an AHP cannot overcome barriers that states might implement to prohibit it from being classified as a large group plan, NAR may not be able to provide a nationwide plan for its members who are asking for more insurance options. It is essential that the final rule clarify that while states may continue to regulate association health plans as they do now, they may not use existing authorities to undermine the final rule. NAR also believes that the department should reconsider eligibility criteria to be considered a working owner, especially the disqualification of those who have an offer of a subsidized coverage from a spouse's employer. The rule's current restrictions could drastically limit the potential pool of members that may be eligible for an NAR health plan. More importantly, this restriction could bar these individuals from an association plan that could provide better or more affordable coverages. To close, reducing the cost of health insurance while maintaining quality coverage is a top priority for NAR, a priority that is shared by the growing number of small businesses and self-employed Americans who are part of every sector of our economy. NAR is encouraged by the administration's focus on making improvements in this area and the committee's attention to the health insurance challenges that face self-employed real estate professionals across the country. Thank you again for this opportunity to represent the realtors' health care concerns.
Thank you. Now I recognize Mr. Ahrensmeyer for your 5 minutes of testimony. Thank you.
Good morning, Chairman Wahlberg, Ranking Member Blunt Rochester, members of the subcommittee. I'm the founder and CEO of Small Business Majority. Our mission is to empower America's 28 million entrepreneurs to build a thriving and inclusive economy. Working from 9 offices across the country, we work closely with more than our network of 55,000 small business owners and over 1,000 local business organizations. Over the past 6 years, the ACA has provided health care to more than 20 million individuals who otherwise couldn't access coverage, millions of whom work for small employers or are themselves business owners or self-employed individuals. Equally important, the small group market has seen rates stabilize under the ACA with an average cost increase of 5.2%, down from a rate of more than 10% prior to the ACA. It should come as no surprise that scientific polling we conducted last year found that 6 in 10 small business owners favor retaining and strengthening the ACA. That's why we're so concerned about the proposed changes in the Department of Labor's rules governing AHPs. In order for small businesses to receive affordable coverage, the small group market's risk pool must be robust and well-balanced. The proposed rule would allow associations to operate as a single large employer, thus creating separate risk pools for different types of small businesses, particularly when it comes to things like essential health benefits, age rating, actuarial value, adjusted community rating, the single risk pool requirement, and risk adjustment. While this might mean that some small businesses with younger, healthier employees can purchase cheaper plans, the remaining risk pool becomes unbalanced, causing rates to soar for everybody else. What's more, the proposed rule suggests that current protections against discriminatory marketing practices would not apply to AHPs, which would allow these plans to discourage enrollment from companies with employees that have expensive or complicated health issues. Under this proposed rule, AHPs would also offer fewer consumer safeguards. It's concerning that the proposed rule is ambiguous about whether it will block states' abilities to regulate AHPs. It's unacceptable to prevent state insurance commissioners from enforcing rules they deem to be in the best interest of their state's small businesses and consumers. Small business owners may turn to AHPs in search of lower-cost options, but without protections in place to prevent fraud, they can find themselves the victims of scams, on the hook for costly medical expenses for issues they thought their plan covered. As Adam Rushan, the owner of a small independent insurance agency, says, the bottom line is AHPs are only good as long as you don't get sick. Importantly, AHPs are not a new idea. In fact, states have already experimented with these plans with disastrous results. An Urban Institute analysis of Oregon's regulations of AHPs prior to the ACA found that policies and lack of regulatory oversight increased the potential for adverse selection in the remaining small group market in the state. This issue, as well as the concerns outlined above regarding fraud and abuse, is why a coalition of 17 attorneys general recently submitted comments to the Labor Department opposing the proposed rule. As noted in their comments, the proposed rule undermines the intent and structure of the ACA and is also contrary to the Labor Department's long-standing interpretation of ERISA, which, among other things, requires that large groups have a, quote, common economic or representational interest, close quote, unrelated to the provision of benefits. Finally, much has been made of the proposed rule's inclusion of independent contractors, or so-called working owners. This is a group that has dramatically benefited from the ACA's individual market, with as many as 1/3 of participants in California's exchange being sole proprietors. As such, enacting this rule would significantly weaken the individual markets. Rather than pursuing policies that undermine the ACA, we encourage lawmakers to advance legislation that would stabilize healthcare marketplaces and protect the robustness of coverage options for small business owners, employees, and independent business owners. Legislations like the bill that was recently introduced by the ranking members of the Energy and Commerce, Ways and Means, and Education and Workforce Committees would be an important step in lowering premiums and stabilizing markets. Thank you, and I look forward to answering your questions.
Thank you very much. Mr. Condalucci, you're recognized for 5 minutes.
Thank you, Chairwoman, Ranking Member Blunt Rochester, and members of the subcommittee for this opportunity. My name is Chris Condalucci, the sole shareholder of CC Law and Policy, a legal and policy practice that focuses on issues relating to the Affordable Care Act. I am also an ERISA attorney by training. I want to start today by saying association health plans, or AHPs, are not the same as short-term health plans. For months now, critics of AHPs have publicly stated that similar to short-term health plans, AHPs can deny a person coverage if they have a pre-existing condition, can refuse to cover preventive services, and can impose annual and lifetime limits. I want to say unequivocally and emphatically that these statements are incorrect. AHPs, as a group health plan under the law, are subject to the ACA's coverage requirements, meaning they cannot deny a person health coverage if they have a pre-existing condition, cannot refuse to provide free coverage for certain preventive services, and cannot impose annual and lifetime limits on the federal essential health benefits covered under the plan. Other notable ACA requirements like coverage for adult children up to age 26, free access to emergency care, and the prohibition against rescinding coverage absent fraud all apply. ERISA's notice and disclosure requirements, fiduciary responsibilities, and health claim procedures all apply to AHPs. COBRA continuation coverage applies, and HIPAA prohibits an AHP from developing premiums based on a particular participant's health status. State benefit mandates apply to fully insured AHPs, and state solvency requirements will apply to self-insured AHPs. So now that we've established that AHPs are subject to existing law that requires the provision of comprehensive coverage, I will turn to the Department of Labor's proposed regulations. The proposed rules would allow employers in the same industry to offer AHP coverage to their members nationwide or on a regional basis. Currently, these related employers can only offer AHP coverage within a particular state. This proposed change is critical for national trade associations, franchisees, and companies with cooperative members. The proposed regulations would also allow employers in different industries, but located in the same state or metropolitan area, to form an AHP. This change is critical for local chambers of commerce and other employer-run organizations made up of multiple unrelated employers. Prior to 2011, many of these organizations offered AHP coverage, but were forced to discontinue their plan due to guidance issued by the Obama administration. The proposed regulations would also allow self-employed individuals with no employees, referred to as working owners, to get health coverage through an AHP. This change is critical because working owners have limited options when it comes to accessing health insurance. Some may be able to access coverage through their spouse, but in cases where family coverage is unaffordable or a working owner is not married, the only option is the ACA's individual market, which has proven problematic for those not eligible for a premium subsidy. Lastly, the Department of Labor should issue a class exemption that would exempt self-insured AHPs from the non-solvency requirements of state MEWA laws. A class exemption is advisable because there is a patchwork set of state laws with different rules and licensing requirements, and the lack of uniformity in the law will likely limit the formation of self-insured AHPs. As a former Republican counsel to the Senate Finance Committee who had the opportunity to draft portions of the ACA, I wish the ACA worked better. I wish the individual and small group markets would have evolved into balanced markets where comprehensive coverage is available. But the reality is that did not happen. And the reality is the status quo is not working for many Americans. One way to improve the status quo is by coming up with alternatives to the ACA that will continue to provide comprehensive coverage at a lower cost. And that is exactly what the AHP proposal is. It is an alternative that is going to help millions of employers to offer health coverage to attract and retain talented workers. It is an alternative that is going to help a large number of national trade associations, franchisees, and cooperative-run companies to provide additional benefits to their members and attract new members. And it is an alternative that's going to help working owners who have been struggling to afford health coverage in the ACA's unsubsidized individual market. This alternative will cost less than individual and small group plans, but the coverage will continue to be comprehensive as required under the ACA, ERISA, HIPAA, COBRA, and state law. Thank you for your time. I look forward to answering any questions you may have.
Thank you very much. And again, I want to thank all of our witnesses for being here today. Mr. Condalucci, I'll come back to you in a minute, but I do want to thank you very much for setting the record straight in your testimony. I think that's extraordinarily important. Ms. Monson, in your testimony, you mentioned that because AHPs have a larger pool of enrollees, they can more effectively balance the risk associated with providing health insurance coverage to their employees. For many small businesses, if an employee gets sick, the individual company or franchise may have to bear the increased costs and premiums alone. Do AHPs provide more financial stability for small businesses faced with higher claims?
Absolutely. AHPs will provide financial stability to small business owners. The biggest complaint of all small business owners is the cost of providing quality health insurance to their employees. Many can't afford to. With AHPs bringing down the cost because of the greater pool and lower administrative costs, it will definitely help financially those small business owners. And it really all comes down to competition for great employees. Nobody wants to hire bad employees, but to keep the best employees, you got to have great benefits. And too many small employers can't afford to have the great similar quality insurance that labor unions and large companies do. AHPs will solve that.
Thank you very much. Mr. Condalucci, we've heard from a number of small businesses and employer groups that small group market costs continue to increase and the number of small employers offering health insurance, especially for very small businesses, continues to decrease. How is small group market size currently defined in the states? Is there a significant difference in cost or offer rates between groups that are fewer than 5 or 10 and those that are over 50 or 100?
Thank you for the question, Chairwoman. First, the states typically define the small group market as an employer employing at least 2 and up to 50 employees. As you may recall, the ACA actually changed that definition and moved that up to 100, but that change was, or that change in the law from the ACA was changed by Congress back to 50. So it is 2 to 50 is the definition. To your question with regard to the cost, as it's, let's say, the price for groups that are smaller in size versus those that are 51 and above, the ACA, as many know, reformed the small group market, or enacted reforms to the small group market. And in particular, the adjusted community rating rules, the single risk pool requirement, essential health benefits, and actuarial value all apply to small group market plans. So typically, the prices are not that different between the various groups, because even if you're a small group of 5 relative to a small group of 45 still in the small group market, the prices are typically going to be the same. When you look at the large group market, which is 51 and above, oftentimes the cost in the large group market is lower. There are administrative efficiencies in the large group market that is not present in the small group market, or stated differently. The small group market has a lot of volatility. A lot of small employers dropping out of the market, in and out of the market. There's underwriting issues, and that just drives up administrative cost. And that volatility is not quite present in the large group market, and therefore large group oftentimes has a lower cost associated with it. So those are just some factors between the differences between small group and large group market plans.
Thank you very much. Mr. McGrew, as you know firsthand, healthcare costs are just one of the many budget line items that small business owners have to balance while running their companies. Operating costs, payroll, maintenance, marketing, and many other duties compete for limited time and resources. Can you describe the other costs your business incurs and how healthcare costs factor into strategic decisions, including hiring and expansion?
Thank you, Madam Chairwoman. There is no question that when you're a small business owner, you wear a lot of hats, and we don't have an extensive HR department in our company. Therefore, we rely a lot on outside advisors. We have to count on them for their expertise, and those are costs associated with having them help advise us with regard to these things. If I could spend more time helping my agents create more opportunities and help more consumers, my time is better spent than spending it on regulations and searching for health care options. In the state of Kansas, there are 2 health care insurance plans available in the whole state. We don't have a lot of choices, and so we spend a lot of time trying to figure out if there's a better way to do things. Unfortunately, that's spinning our wheels because we really, at this point, have only very limited choices. Thank you.
Thank you very much, and again, thanks to all of you. Mr. Scott, you're recognized for 5 minutes.
Thank you. Mr. Ahrensmeyer, do AHPs reduce the overall cost of health insurance for everybody? Or just move it around so that different people pay different rates?
They do not decrease the overall cost. There are cost factors in the health insurance market are governed by many underlying issues, and as you're right, they just move it around.
Okay, so if you allow healthy people to form their own AHPs, what happens to everybody else?
Everybody else gets left in a group that's forced to raise prices, and most people are going to have their prices go up.
And what happens to stability if healthy people start forming their own associations?
Well, the stability of the market decreases. Congress decided we've got 3 basic groups, risk groups. You've got large group, small group, and individual, and each one of those needs to be as robust as possible. If you start to weaken any one of them, you weaken the whole system.
Now, if you form an AHP and people start in your program start getting sick, what can they do?
If they're in an AHP, if they start getting sick and the AHP starts to incur losses, the AHP could go away. And unlike a large group, which is there because everyone's got a common economic interest, in a big company, this is a group that's just set up for health insurance purposes only, and it could just disintegrate.
That means they can go back into the normal individual or small market pool.
If they would ultimately have to go back into it, yes, but you're talking about destabilizing a market in the process.
Now, what is the history of insolvency in AHPs?
There's been a tremendous history of insolvency. As I said, again, if you set up an entity for the sole purpose of providing health coverage, you don't have the foundation that you have in the large group market with a large company that's there for many reasons beyond health insurance. So once something starts to go wrong, there's absolutely no incentive for people to stay in the system.
So if the costs go up because a few people got sick, everybody will start bailing, is that right?
That's right.
Is it possible to design a benefit package that attracts healthy people rather than average people?
Absolutely. I mean, if you don't have the same rules regarding essential health benefits, you create different rules of the road. The reason that, and I should add, as I said in my testimony, the small group market, unlike some of what you've heard, has actually been relatively stable. In fact, between 3 and 199 employees, it's only gone up 1% in the last year. So that's how you have a stable market, is you have as much risk spread out as possible.
But if you had designed a program that you didn't have services for diabetes, didn't have chemotherapy, you didn't have AIDS medicine on your formulary, you would discourage people with those diseases from joining the pool, is that right?
That's correct.
And you would have a healthier pool as long as they stayed healthy, and everybody would be happy until somebody got sick.
That's correct.
Can you give some examples of what happened? You mentioned fraud. What happened? Can you mention what happens when people get defrauded in this situation?
Well, if they think they're signing up for comprehensive health benefits and then all of a sudden the AHP weakens, then they're out of luck.
What happens when the AHP goes insolvent?
The people don't have coverage anymore.
We've heard that nobody's going to really sell these skimpy plans because nobody would want to buy it. Doesn't a skimpy plan have the advantage of a very low price?
Absolutely. I mean, it becomes very attractive on the surface, and all of a sudden you find out it's not covering what you needed to cover.
And so the whole point of this is to lower the prices, and if you can get a low price, then people would be attracted to it until they get an illness that is not covered. Where they have done these, has the cost of the residual market, those that didn't get into an AHP, have you seen the costs go up for everybody else?
Absolutely. I mean, the cost increases in the small group market prior to the ACA, particularly when you had AHPs in the system, were much higher. I mean, the growth was higher. The rate of increase was higher.
Is there any problem with discriminating based on gender or designing a pool that has traditional male employees?
You can certainly design a pool, design a set of benefits to intentionally exclude or at least implicitly exclude certain people by not having maternity coverage, not having coverage for things that people who are older tend to get. Again, it's about having separate rules of the road than the small group market. The whole point of the small group market, as we just heard from Mr. Condalucci, it's actually you get pretty common costs across the entire small group market because you have a common set of rules and a common risk pool.
Thank you, Mr. Chairman.
I thank the gentleman, and again, thank you for the panel for being here. I apologize for having to leave to go to 2 other subcommittee hearings that are going on at the same time for me. But Mr. Condalucci, there's been a lot of discussion about whether AHPs will provide adequate consumer protections to their members. Some fear that expanding AHPs will lead to discrimination against employees who are older, sicker, or more expensive than other workers. That's been brought out this morning already. Can you discuss which non-discrimination requirements apply to AHPs and how those compare to requirements applicable to existing plans in the large group market?
Thank you for the question. In the Department of Labor's proposed regulations, there is a non-discrimination protection that says that members seeking to join an employer group or a group that is going to sponsor an AHP cannot deny membership based on the health status of that employer member's employees. So there is a non-discrimination protection when it comes to membership in the employer group, which almost by extension is a non-discrimination protection as it relates to participation in the AHP. When it comes to the AHP, there are current law non-discrimination protections, as I discussed, and they're built into the proposed regulations, which say that an AHP cannot vary premiums based on a particular participant's health condition, nor can they vary eligibility for benefits based on a particular employee's or a particular participant's health condition. So those are current law non-discrimination protections that, again, are built into the proposed regulations.
Okay, and group market plans are required to cover pre-existing conditions as well?
Yes, sir. Large group plans, self-insured plans, as well as small group plans and individual market plans are subject to the ACA coverage requirements. And those ACA coverage requirements, which apply to all plans in all of those markets, have a prohibition against denying someone coverage based on a health condition or discriminating against a particular participant based on the health condition of that individual.
Okay, great, thank you. Ms. Munson, you briefly talked about the cost of providing health insurance to your employees, as well as the challenges that franchise businesses can face when obtaining health insurance coverage. How does the ability to offer great health insurance coverage affect your franchisees' ability to attract and retain talent, and what impact do you think that offering an AHP would have?
Thank you for the question. Every business requires the best employees to be the most successful that they can be. And small employers have really struggled. Franchise businesses with small staffs have really struggled to find that same level of quality care, quality health insurance at a reasonable price. My franchisees every day compete for the same employee candidates as large corporations do.
So competition is real.
Competition is real for great employees, and we need to help those small business owners and those franchise business owners have access to quality, affordable health insurance. AHPs will bring that so that they can have a level playing field when competing for the best employees, hiring the best employees and keeping the best employees.
Okay, thank you. Mr. McGrew, cost is a significant concern for small employers who want to offer health insurance. Do you believe that AHPs can offer the independent contractors you work with more affordable health plans, and they can find it and purchase it today?
Thank you, Mr. Chairman. Absolutely. I am very confident in my case that the National Association of Realtors would be able to provide an option for my independent contractor realtor family members. There are so few choices when you're in the individual market that are good choices. And to have another option from a valued, trusted business partner, as the National Association of Realtors is, would, I think, be a very valuable and viable option for my realtor family.
Mr. Condalucci, excuse me, Ms. Munson, I want to go back to her. Can you describe how an AHP would help small employers manage the administrative costs of their plan?
If I take a look at the International Franchise Association, representing 733,000 franchise businesses, with the stability of great coverage at an affordable price, there's not going to be the small businesses joining and leaving all the time. That reduces the administrative cost. There's a certain administrative cost that goes over one company, no matter if it's small or if it's very, very large. And so then we can spread the administrative cost over millions of employees or thousands of employees or hundreds of employees rather than just 10 or 15 or 20.
See, my time has expired. Thank you. I recognize Ms. Blunt-Rochester for her 5 minutes of questioning.
Thank you, Mr. Chairman, and again, thank you to the panel. As I listen to the conversation, one of the things that becomes clear to me is that we all value affordable, quality health care and access to it. I think one of the concerns and one of the reasons why my focus has been on strengthening the Affordable Care Act is because, to me, this is kind of going backwards. It's saying we're piecemeal as a country instead of all in this together. So I start with that premise, and I thank the panel for your testimony. Mr. Condalucci, I will probably ask you some questions later based on the new testimony, so I'll come back to you with some of that later. But I would like to ask a question starting with the fact that the Affordable Care Act, what was really powerful about it was that it afforded protections to older consumers, particularly as more people are living longer and staying longer in the workforce. And I worry that older business owners and older workers who could be left with fewer options or even more expensive coverage under this rule. AARP states in a comment letter that the rule could, quote, greatly increase the likelihood that working Americans, especially those aged 50 to 64, would face higher insurance premiums and the loss of access to critical health insurance coverage. Mr. Arensmeyer, are you concerned about the impact that the rule could have on older workers?
Absolutely. If you just look at the large group market now, the age banding between the most expensive for older workers and the least expensive is 5 to 1, whereas in the small group market, as you know, it's 3 to 1. So you're automatically talking about a situation where you would have relatively higher prices for older people, which would then create problems for small businesses with older workforces.
And another thing that concerns me about the rule is that it could discourage businesses with employees who have pre-existing conditions and health issues, or even people with disabilities from enrolling in association health plans. For example, right now, small group plans must cover habilitative services, but under the rule, this requirement would not apply. In your position, would a plan without that coverage be attractive to, for example, a small business owner with a physical disability?
No, it wouldn't. And again, it gets back to the fact that you've got different rules of the road. We've heard a lot about the fact there'd still be certain prohibitions against overt discrimination, but that doesn't stop you from setting up a plan that has different benefits than the essential health benefits required in the small group market, and thereby discouraging people who might be higher health risks from joining that plan.
And my last question, earlier this week, the president announced his plan to combat the opioid crisis. And while I don't think we're going to debate the plan here, I will mention that I think it's really encouraging that the president and Congress are having this important conversation and actually having it in a bipartisan way. But I'm a little nervous about the rule and that impact on association health plans to avoid covering needed services for substance use disorder, entirely counterproductive to what we're saying that we're trying to do with stemming the opioid crisis. Would you comment on the importance of substance use disorder treatment and why maintaining coverage for essential health benefits is important?
Well, again, it gets back to the fact that you have different rules for different risk pools here. And there's no question you could, again, design plans that had less coverage for drug abuse treatment, and you'd then be skewing the market accordingly. So again, I'm going to stress that in the large group market where you have common economic interest in a company, there's an interest in covering everybody, with the best benefits as you can in that company. When you set up a plan or an organization or association that is purely for the purpose of providing health coverage, you don't have that, and you don't start off with a pool of people that you want to cover. You're saying, we're going to set up this particular plan, and then we're going to attract people to come into it. By definition, you're then skewing the risk pool that's in that market, making it not only different from the small group market, but different from a large group that's actually representing a company.
I'm just going to close out by saying the committee knows I've served as Deputy Secretary of Health and Social Services, Secretary of Labor, State Personnel Director. This issue of healthcare cost and quality has been one that has plagued us for many, many years. We need to all be on the same page and be doing it as one country, not a lot of different separate groups. Thank you, and I yield back.
Thanks, Gentlelady, and I recognize my friend from Tennessee, Dr. Rowe.
Thank you, Mr. Chairman, and I have been in the small group market when we started our practice and grew now to the large group market. I've also served as a mayor of my local community where we did self-insurance plans, so I have a fairly good understanding of the market. I also have the Affordable Care Act, and have had 2 major operations in the last 18 months, one for cancer, and I would have been better off with each one of them just to have written a check. It would have been cheaper. In my district, almost as many people pay the penalty last year has got a subsidy. So it isn't working like a charm in the 1st Congressional District of Tennessee. I'll just start by saying that. Now, secondly, I could not agree more that we want to increase the access to care to people, lower cost, and increase quality. I have a good friend of mine, I won't mention it, he has over 15,000 employees in his business. He has been able to put a health maintenance plan in that business, and we know what the drivers are: hypertension, diabetes, obesity, smoking, cancer. We know what those are. And with a large group like that, you can manage your health care costs, and he's been able to keep those at 1% level for the last several years. Why in the world would we put a roadblock up to keep these small business owners from doing the same thing? I know you are absolutely right, Ms. Munson. One of the hardest things to do, and one of the most valuable people in my office were my employees in a doctor's office or in a realty office. Good people are hard to find. They need this coverage for their families and themselves, and they need it affordable. And the way you can provide that is getting a larger risk pool. And look, we had great employees who had serious health benefits. We wanted to provide, as an employer, I wanted to take care of those people. Not only in a small business, these are not just employees, they're your friends. You may have worked with them for 25, 30 years, which I did routinely. And I found out when we got older, things happened to us. We didn't abandon those people. And it's offensive to me when people come up here and say that I would do that, or that small business owners would do that. So I know them, I work around them, and by the way, we have this Christian Sharing Ministries that has grown dramatically after the Affordable Care Act, simply because coverage costs went down. And Ms. Munson, you made a comment, and I think you'll find this with all small business owners. If they could find a product that was affordable, that offered quality coverage for their employees, they would buy it. The problem is cost, and that's how do you get the cost down? And I agree with you all, how do you provide a quality product? So I think, Mr. Condalucci, I read your testimony last night, and you made some incredibly good points in here, is that this is not a fly-by-night plan. These are quality plans that are governed by ERISA. They're in a different silo, agreed, than the small group market. And one of the comment, Mr. McGree, that you made was the two insurers in the state of Kansas. Well, if I were those two insurers, I wouldn't want any competition in the state of Kansas. I certainly wouldn't want an association health plan where my people there could buy insurance from somewhere else. And in Alabama, I know there's a dominant player in that market. In Tennessee, there's a dominant player in the market. So I bring these up, and Ms. Munson, back to you. I want you just to, again, comment on the importance of your employees in your franchise business. And quite frankly, if 10% of franchise employee workers would get health insurance, you'd have an incredibly large 700,000 to 1 million people in a market. And believe me, you can control costs doing that.
Thank you. It all comes down to competition and competing for the best employees. And the best employees, they're smart. They understand. You know, I keep hearing this, we're going to provide skinny plans or poor coverage. That's not the case. People today are educated. The employment candidate is going to ask questions about the health insurance. They're going to know what it covers. There is no upside for any employer to offer subpar health insurance because we care about our employees. We want them to be healthy. We want them to continue and grow within the organization and to remain. There's no incentive to have lousy coverage, only good coverage. And thinking about the 7.6 million employees that work for the 733,000 franchise establishments in the U.S., what an amazing large pool. Think about the buying power. It's all buying power.
Well, one of the last thing I'll say before I close up, one of the things I wish the AC had worked as well, and it has for some people, but it has failed a lot of people. And what we're seeing in our practice is with the out-of-pockets and co-pays so high, people come get a preventive service. But then if you find anything wrong with them and you have to send them down to the hospital or wherever to a diagnostic center to get testing, all of that's on their nickel. And if you've got a $4,000, $5,000, $6,000, $7,000 out-of-pocket, you just don't get it done. So I think this is an incredible opportunity. I'm excited about this. I think it would be fun to see this, if this could work. I know it will. Thank you. I yield back my time.
Thank the gentleman. I recognize the gentleman from New York, Mr. Espay.
Thank you, Chairman Wahlberg, for this opportunity. I ask for unanimous consent to enter a comment letter submitted by state attorney generals in opposition to the Department of Labor's proposed association health plan rule?
Without objection, hearing none, it will be submitted.
Thank you, Mr. Chairman. Mr. Chairman, as I said, 16 state attorney generals and the Attorney General from the District of Columbia have submitted this comment that stipulates, in fact, that they have great concerns with this proposed action. And Mr. Chairman, here we are again talking about association health plans, an idea which has failed time and time again. As our attorney generals have said, their state and respective offices have the duty and experience of protecting consumers from predatory practices associated with HAPs. But this proposed rule will threaten those very protections and open up consumers in states and regions across the country to the real potential of fraud and catastrophic wrongdoing. Almost 75 pieces of legislation dealing directly with HAPs have consistently been introduced in Congress, dating all the way back to the 103rd Congress. Let me repeat this again. Almost 75 pieces of legislation dealing with these issues have been consistently introduced in the U.S. Congress, dating back to the 103rd Congress. Of those almost 75 pieces of legislation, 9 bills have passed at least one of the chambers of Congress, and of those 9, not one has been signed into law. Additionally, during that time, then Secretary of Labor Elaine Chao's testimony on HAPs in 2013, it was clear that the Department of Labor did not have the authority to act on AHPs without legislative action from Congress. This effort will lead to segregating the insurance pool into one that has healthy young people, people with pre-existing conditions, and the others will have seniors, people with catastrophic illnesses, people with pre-existing condition, poor people. That's what this action will do. This tells me 2 things. One, there has never been enough support of confidence in this kind of association health plan proposal to actually authorize them through federal legislation. And 2, until now, the Department of Labor have never believed it had the authority to establish these kinds of HAPs on its own. In fact, this proposal is directly opposed to the ratified congressional intent of both ERISA as well as the intent of the ACA. Aside from the massive enforcement issue, potential for widespread fraud and abuse, and as well as the constant legal battles that will be attached to HPs, it seems to me that the Department of Labor requires congressional authority to implement these rules, and the department quietly simply lacks that authority. My question is, recognizing that Mr. Condelucci found it acceptable to submit a brand new testimony this morning, which I'm going to completely ignore, I'm going to ask Mr. Arensmeyer this question. I represent New York's 13th Congressional District, which is home to many small businesses that are critical to the local economy, our neighborhoods, and workforce. If implemented, what exactly does this proposed rule mean for those small businesses and the health of their employees?
What it means is if they don't find the AHPs that they may have access to, if they don't have the kind of benefits they want, they are left in the core small group pool, but by pulling out the participants in that pool that are healthier and younger, their costs are likely to go up. Or if they chose to join an AHP, they're at risk. They don't have coverage for certain needs that they might have.
One last quick question, as I'm running out of time. How does this impact the ultimate risk factors that are considered for any pool of insurers?
Well, again, I mean, it comes down to you want as broad and robust a pool as possible. And there's operating by the same rules of the road. So when you start to play with that and you start to pull certain people out of a pool, you start to create instability in the whole marketplace. I mean, we're all for competition, and we'd love it if there were more group plans participating in the small group market. So again, if they come in playing by the same rules, that'd be great. We all are concerned about costs. There's underlying costs in the system we need to deal with. It's a question of people in common pools that are joined by a common economic interest.
Thank you, Mr. Chairman.
Thank the gentleman. I recognize the gentle lady from Oregon, Ms. Bonamici.
Thank you very much.
Oh, excuse me. Excuse me. Saw you hustling around there and can't keep track of the players here. So take your time, get in place. And now I recognize the gentleman I never want to slight, the gentleman from Minnesota, Mr. Lewis.
Thank you, belatedly, Mr. Chairman. I'm a little perplexed as to the opposition to expanding these small business pools. For many, many years, we've had large businesses operate under the notion of, say, a self-insured plan to get out from under very onerous state mandates. They obviously had purchasing power advantages in large networks that small businesses didn't have. So the idea of granting in these association health plans that same purchasing power, economies of scale that self-insured plans had or that larger businesses had, seems to me to be something that wouldn't generate much opposition, especially since you look at the status quo, and as the committee has pointed out, since 2008, the share of small businesses with fewer than 10 employees offering coverage at all has dropped nearly 40%. In my home state of Minnesota, just since 2013, in the implementation of the Affordable Care Act, some 7,000 more small businesses have dropped coverage. So we do have a crisis here. It seems to me, Mr. Condalucci, that therefore the fallback provision of the opponents of this is, well, if you allow these pools to form, why they'll be offering these skimpy plans. Now, you know, my parents used to buy something called Major Medical. When we understood what real insurance models looked like, we realized that your automobile insurance doesn't cover the tires, doesn't cover the oil change. If so, it would be sky high. And therefore, health insurance for many, many years used to cover a catastrophic event that could bankrupt a family. But if you took Johnny or Susie to the annual physical, you paid it. We've now, with the Affordable Care Act, gone the other way. We ought to have first dollar coverage on everything. I don't want any copays. I don't want any deductibles. And we put this system on the market, and all we're left with are spiraling out of control premiums. But isn't it true, Mr. Condalucci, that for many, many years, businesses, especially self-insured, were trying to get out from under very costly state mandates for that very reason, right?
Yes, state self-insured plans have ERISA preemption protections, and therefore the state benefit mandates do not apply to those self-insured plans, and therefore the cost associated with a self-insured plan is typically lower, while employers, be it small, be it large, that are sponsoring those self-insured plans offer comprehensive coverage that are almost as comprehensive as the essential health benefits, as well as many of the state benefit mandates that would have otherwise apply
and those
for
people,
ERISA preemption.
Those people under self-insured plans weren't shortchanged. They had very good health insurance, but the fact is there were costly mandates in my home state of Minnesota that some larger corporations wanted to get out from under to tailor a health insurance plan to fit their employees. And they had that option, but small business didn't have the option. But it's also true that the Affordable Care Act wanted to limit that, and therefore came up with these essential health benefit plans. So the notion that they could get out from under those, under the ACA, simply by an association health plan is erroneous, is it not?
Yes, it is, sir. And it's important to understand that employers offer health coverage to attract and retain talented workers. And small employers compete with large employers for talent as well as they compete with their own small employer peers. And those small employers are going to seek to offer comprehensive coverage. And virtually every large employer out there offers coverage that includes the essential health benefits or offers coverage that is actuarially equivalent to the essential health benefits. So the claim that these association health plans will offer skimpy plans, I think, is difficult to accept, just basically seeing what large employers out there are offering. And I will note, the drafters of the ACA specifically exempted large group fully insured plans and self-insured plans from the essential health benefits requirement, as well as some of the other insurance market reforms, because the drafters accepted the notion that these large employers were offering comprehensive enough coverage, and therefore the drafters said, why should we impose these requirements when these employers
so
are
if it's
already
good
doing
enough,
the right thing?
if it's good enough for those large employers, it's probably good enough for small business, isn't it?
Yes, sir.
Having said all of this, isn't it true, however, that we've got to get back to the notion of a catastrophic health insurance policy that allows people to buy coverage that starts, quite frankly, with a very low deductible, but that wouldn't bankrupt their family? Instead, we've gone down this road of prepaid medicine, thinking we're going to have first dollar coverage, and that's an impossibility in most insurance markets, isn't it?
Yes, sir.
Thank you so much. I yield back.
I thank the gentleman, and now I recognize again the lady from Oregon, Ms. Bonamici.
Thank you very much, Mr. Chairman and Ranking Member, and thank you to our witnesses for being here. I used to do financial counseling at Legal Aid, and I would work with clients who were devastated, oftentimes by healthcare costs, and some of them just could not afford insurance, and some of them had insurance, but it didn't cover them when they needed it. Also, when I was in private practice, I represented franchisees, and I know how hard they work, often family-owned businesses, and I know they want to do right by their employees. And even before that, my first job was in my mom's small business. I understand and know how important small businesses are to our communities, to our economy, and of course, we all want small business owners and employees to have access to affordable, accessible health care. But I'm very concerned because we've seen a great deal of evidence suggesting that association health plans do not work as intended. Now think back to before the Affordable Care Act, which passed before my time in Congress. We knew that people who could not afford insurance would get their health care in emergency rooms, which is the least effective, most expensive way to get health care. Those costs would get passed along to everyone. So, and even Dr. Rowe recognized the ACA works for some people. What we should be doing is we should be strengthening the Affordable Care Act by providing certainty for insurers. We should be strengthening and stabilizing the individual and small group markets. That's what would really make a difference. Mr. Chairman, I would like to introduce into the record a letter addressed to Secretary Acosta from the AARP, in which they note the proposed rules expansion of AHPs could greatly increase the likelihood that working Americans, especially those age 50 to 64, would face higher insurance premiums and loss of access to critical health insurance coverage.
Without objection and hearing none, it'll be introduced.
Thank you, Mr. Chairman. Mr. Arnsmeyer, you referenced a letter signed by 17 state attorneys general, including Oregon's Attorney General Ellen Rosenblum from my home state. Could you explain why these attorneys general are so concerned about this rule and their ability to enforce state regulations on association health plans?
Well, based on the letter, I think they're concerned about a lot of the concerns that I've raised here about separate risk pools. They're concerned that, particularly in the interpretation of ERISA, that ERISA is based upon regulating plans that may not have the same rules as a small group market, but they are based on a common economic interest in the, among the participants in that plan. So again, we've heard a lot about comparing large group plans with the AHPs. I mean, large companies like General Motors, IBM, Google, they have an interest in providing comprehensive coverage. We've heard that they most of them provide essential health benefits because they have an economic interest in doing that. There's no common economic interest in an association health plan that is set up purely to provide coverage and could go away tomorrow. That's not the case with a large group plan. Google's not going to get rid of its large group plan tomorrow because there's some issues with risk in it. So again, they're concerned that that ERISA, the way it was written and the way it's been interpreted, that this flies in the face of that. It's also concerned that it flies in the face of the intent of the Affordable Care Act.
Thank you. And I noticed in your testimony you mentioned an Urban Institute analysis of association health plans in Oregon prior to the ACA. That analysis found there's increasing potential for adverse selection in the state's remaining small group market. Could you just briefly summarize that study and comment on whether this proposed rule might lead to adverse selection.
Well, again, it gets back to what I'm saying. If you have something that's set up with separate set of rules, it's purely to provide health coverage. You don't have the built-in protections, just sort of market protections that you have with a normal large group plan. So there's a tendency to maximize, to try to keep the costs down by reducing benefits, and by, at some point, then people start to get sick and they're not covered, and the whole system.
Thank you. I want to get one more quick question in, I know you said Condoleezza. I want to say Condoleezza, but. It's been referenced before. There's been a long and well-documented history of health insurance scams promoted through AHPs. According to the GAO, between 1988 and 91, operators of multiple employer entities left about 400,000 people with medical bills. There's just a whole history here. The Department of Labor does not address the fraud that's prevalent in this market. There's no clear indication of how the rule would protect consumers. So what would the Department of Labor need to do to prevent fraud and protect legitimate associations or small businesses or self-employed individuals from being scammed?
It's a very fair question. And it's important to note that because a lot of folks overlook the fact that the ACA, driven by the GAO report and the investigation on fraudulent activity, led to actually enactment under the ACA additional enforcement authority for the Department of Labor. So the Department of Labor now can actually impose civil and criminal penalties if there's fraudulent activities in these self-insured or fully insured AHP-type plans. In addition, the DOL can go in and seize assets if there's a solvency concern without a court order. So there are now enforcement tools that are in the law that have been offered to the Department of Labor, which many would argue have contained many of the fraudulent activity that occurred in, let's say, the early 2000 to, let's say, the 2004 timeframe. And Congress does have the ability to provide additional funding to the Department of Labor to increase that authority, that enforcement authority, and or provide additional tools to ensure that there are not fraudulent activity and therefore containing much of the concern and much of the fraudulent activity that has happened in the past.
Thank you. I see my time has expired. Thank you, Mr. Chairman.
Very adeptly done to get that last question in. I thank the gentlelady. Now I recognize my good friend and colleague from Michigan, Mr. Mitchell.
Thank you, Mr. Chair. Let me start briefly, Mr. Ernstmeyer, with a comment for you. I led a couple of small businesses, one that evolved into a fair-sized business. Was chair of association of those small businesses. I'm astonished and frankly a little offended with your comment that somehow there's not a joint economic interest, that we do not have the same level of economic interest in the well-being and health of our employees as large businesses do. And I think it's based on that very premise with which you go forward with your testimony. So your position, of course, is you're welcome to it. It's noted, but I think it's based on some false premises. I was extremely concerned with the whole wealth and well-being of our employees. Let me go through a little history, as with Dr. Rowe. I was in a large group plan with Chrysler Corporation, a self-insured plan. We had a business that grew to 650 employees, and we had part-time employees that were teachers and instructors that worked some less than 15 hours a week because they were instructors. During the economic downturn, we created a health insurance plan for employees that were regularly scheduled at least 9 hours a week because, frankly, in many cases, they were female employees. Their husbands were losing jobs in the auto industry, and they had no health insurance. Along came the ACA, which by definition, because we had this plan as an option we created for our part-time employees, created obligations that, frankly, we couldn't afford for part-time employees, some of which worked as little as I said, 12 hours a week. It created obligations that we had to make a choice between continuing insurance for our employees, which we did because we thought it was necessary for them and their families, or telling them to go to the Affordable Care Act. Huge obligations that no one seemed to care much about. I met with a large employer recently, a large hospital recently, that told me 2/3 of their ER cases should go to primary care or urgent care, but still come to the ER. The Affordable Care Act has failed to deal with the fundamental problems which we're kicking around today. A lack of transparency of cost and choice. Try to find out what the cost of a MRI at a clinic versus an MRI at the hospital are. Let me know how that works for you. Second is a lack of user input and involvement in the cost and choice. And third is a lack of competition on what the cost is. We've disassociated the user from the cost, and now we're trying to paper it over with one reg after another. And until we fundamentally deal with the Affordable Care Act, fundamentally deal with what we're not talking about, which is the cost of health care in this nation, and people having a choice and understanding what their costs are, we're going to continue to try to move costs around from one group to another, and then hope the government will pay for it, the taxpayers. So while we talk about this plan today, the longer we sit here and hope that the federal government is going to somehow find a way to milk the taxpayer to pay costs for someone that doesn't know what their cost is, that goes to the emergency room for care, they could go to urgent care because that's what they've done their entire life, our health care costs will spiral. And we should do that. We should actually take the effort to do that here in Congress. A couple of quick questions. I'm running out of time, and I apologize, but it frankly frustrates me. Ms. Monson and Mr. Carlucci, I apologize for the pronouncement, sir.
Quite all right.
Is there some reason that there wasn't or some explicit language put in place on the joint employer to exclude them or to clarify the exclusion so that, in fact, it doesn't create a further risk of being defined as joint employer? Can you help me on that?
I know that the International Franchise Association has made a request that we have a safe harbor because we do not want to have the risk of being deemed joint employers just because there's this valuable, affordable, quality health care plan available, whether it's through the fast sign system or whether it's through the International Franchise Association. It's certainly a request we've made.
Well, given all the conversation we've had, including with the Secretary of Labor, both here and in meetings, about the joint employer rule, I'm frankly astonished that there wasn't something done in the regulation to, in fact, address that. I don't understand why, and I think by letter I may well participate in making a comment on that because I don't understand why it is they didn't address that. It's been a huge conversation around here, yet it's ignored by the department, frankly. One more quick question, as I know I'm going to run out of time, but I'm going to see if I can use my colleague, Ms. Bonamucci's time. You note, Mr. Carlucci, a potential conflict between state law or potential state law and the redefinition of large group AHPs by state law saying there's small groups and causing issues there. How do you propose they resolve that?
Because first, the proposed regulations do nothing to change state regulation, so therefore states could, if they so chose, enact a law that recharacterizes a large group plan, large group fully insured AHP as a small group plan, therefore subject to small group market rules. And there is an argument that that could be subject to an ERISA preemption challenge.
Sure.
And in addition, there is certain language in ERISA that regulates or that requires states to impose certain regulation on fully insured MEWAs or fully insured AHPs. And a recharacterization law such as this is arguably inconsistent with the ERISA statute as it relates to regulating fully insured MEWAs at the state level.
Thank you, sir. One quick comment, Mr. Chair, is I did review real quickly the letter from the 16 Attorney Generals opposing this regulation. It won't shock you to know, Mr. Chair, that all 16 Attorney Generals have explicitly expressed in no small manner their support for the current Affordable Care Act, such states as New York, Massachusetts, and California, so that will state a great deal of their rationale. Thank you, sir.
I thank the gentleman for doing your homework. Now I recognize the gentlelady from Florida, Ms. Wilson.
Thank you. I want to begin by thanking our subcommittee chairman, Wahlberg, and ranking member Sablon for holding today's hearing, and I would like to thank our witnesses for your testimony and for being here today. I ask unanimous consent to enter into the record a comment letter in response to the proposed rule from the American Cancer Society Cancer Action Network.
Hearing no objection, and I hear none, it will be entered.
I strongly believe that if the Department of Labor's proposed rule is to expand association health plans goes into effect, it would seriously undermine many of the benefits offered under the Affordable Care Act, mainly by weakening consumer protections and shifting costs onto working people. Indeed, the underlying effects of association health plans limit access to comprehensive health coverage, increase costs for consumers, and threaten coverage for people with pre-existing conditions. Moreover, they leave consumers with even fewer protections against fraud. Certainly without guaranteed coverage for essential benefits such as maternity care, mental health treatment, and substance use treatment, many people may be left with inadequate coverage that neither gives them access to the care they need nor offers adequate financial protection against serious medical conditions. And in fact, the proposed rule goes so far as to explicitly state that some association health plans might thrive by delivering savings to members by other means, such as by offering less comprehensive benefits. In addition, these plans would increase cost and threaten coverage for people with pre-existing conditions, as healthier and lower-cost consumers get cheaper plans with less benefits that may not meet their health care needs. Association health plans would leave older, sicker, and higher-cost consumers or consumers with pre-existing conditions behind in a traditional market with skyrocketing costs, making it outright difficult to obtain coverage. Now I want to ask a few questions of our witnesses. Mr. John Arismeyer, you stated in your testimony that because most small businesses currently purchase coverage in the small group market, it is important to protect the stability of this market. In your opinion, does the proposed rule contribute to stability, or does it undermine it?
We believe it undermines it, and again, as I said before, by removing certain participants in that market who are likely to be at a lower risk, thereby leaving higher risk folks in the small group market and increasing costs and increasing instability.
Under the proposed rule, associations tied together by the same industry or geographic area can form solely for the purpose of offering coverage. This means employers could form a new organization for the sole purpose of achieving savings by avoiding many of the Affordable Care Act's consumer protections. But what about small businesses and workers that want these protections? If they choose to stay in the traditional market, what could the rule mean for them?
Well, obviously, if they choose to stay in the existing market and you remove higher risk out of the lower risk out of the small group market, you're going to end up with higher costs and more instability in what's left, and it's going to jeopardize the protections that they have. Again, it's really about we welcome competition, and there's been a lot of talk about cost reduction. Absolutely, there's a lot of need to reduce the healthcare costs in the whole system, but at the same time, if we're going to be talking about coverage and robust and stable markets, we have to have everybody playing by the same rules.
What role do you think states should play in regulating these health plans?
Well, traditionally, states have played a very significant role in regulating health coverage. And right now, it's unclear. And as Mr. Condalucci said, there's states may believe they can still regulate these or recharacterize these groups as small group, but there would be a likely challenge under ERISA. So it again creates legal instability on top of the economic instability.
Mr. Michael McGrew, in its proposal, DOL speculates that associated health plans will generate substantial inefficiencies that result in cost savings for their members, but provides no evidence and no actual numbers to support its assertions. What specific administrative functions will you perform more efficiently than an insurer, and what % savings does that yield?
Thank you, Madam Congresswoman. I am not an insurance expert, but I would say that from the standpoint of the National Association of Realtors, if they were given the opportunity to provide a AHP plan to our 1.3 million members, we would certainly benefit from the fact that the National Association of Realtors has a robust value proposition to offer the rest of us who are small, independent, and individual company owners who do not have the time and the ability to do the kind of work that you're suggesting.
I thank the gentlelady. Her time has expired. I recognize the businessman and gentleman from Pennsylvania, Mr. Smucker.
Thank you, Mr. Chairman. Mr. Guru, your testimony underscores what I heard just recently in a meeting with realtors and their association in the district that I represent. I think top concern for them was healthcare. And I think all of them in the room, or almost all of them in the room, were covered through the individual marketplace and are experiencing the kind of things that we've been hearing here: high costs, prohibitive premium costs, and very high deductibles. I know in other situations I've heard individuals who really wanted to go into business for themselves, but saw the cost of healthcare as a barrier to entry, essentially. Are you finding that with realtors as well? Are they making decisions not to go into real estate because of the cost of healthcare?
Absolutely. There are career decisions being made every day based on your ability to get health insurance. And it's interesting to me, the entrepreneurial spirit that is embodied in the realtor community is prevalent around the United States as well. And why is it that individual sole proprietors that have this spirit are discriminated against, if you will, from having the ability to access the more affordable healthcare markets?
That's the way I see it. And it was mentioned earlier that we want to ensure that everybody can get to play by the same rules. And I think we've seen tremendous opportunities, tremendous prosperity in our country because of unleashing individuals' ability to start a business, to grow their businesses. But today, and I was an owner of a large enough business with several hundred employees that could self-insure. First of all, we had a large enough pool we could buy our own insurance, but as we continued to grow, we were able to self-insure. And being able to attract employees from other businesses, the health insurance that we had available for them was often the deciding factor in being able to pull them away from another, maybe potentially smaller business. So it really isn't a level playing field today, is it?
It does not feel like that, no, sir.
And how do you find that as well, Ms. Monson?
I do find it as well that us as small employers don't have the same opportunities to get affordable health care for our employees as large employers and labor unions do, and it puts us at a competitive disadvantage.
Mr. McGrew, back to the realtors, what percentage of, in the event that the association could put together an AHP, what percentage of realtors do you think would participate in that?
Well, from the standpoint of viewing that as an option, I think virtually all of them would. Today, 90% of our members are covered one way or another, many of them through their spouses. If they had the opportunity to see better options that are provided from a brand they trust, a brand they already do business with, the National Association of Realtors, I believe many of them would seriously consider that as an option.
Ms. Monson, one of the things that I've noticed as well is that small businesses, particularly businesses under maybe 10 employees, have just simply given up on being able to provide health care for their employees. The employees go to the individual marketplace and then are faced with the kind of high costs that we're seeing. Are you finding that with your franchisees as well?
Yes, I am. I find that with our Fast Lines franchisees and also on a recent survey that the International Franchise Association conducted with its $733,000 franchise location members. 65% don't provide health coverage, primarily because of the cost. But then when they were asked the follow-up question, if quality affordable insurance was available through, say, an IFA AHP or some other AHP, and let me just clarify, IFA is a bona fide association. This is not a fly-by-night deal. We are not looking to make a quick buck by getting into the association health plan market. This is about taking care of our members and our members' employees. We have a fiduciary responsibility. We care about our brand. We would never do anything to hurt our brand. So when I hear accusations that it's fly-by-night, that we're just going to put something together to make a quick buck, nothing could be further from the truth. And in that survey of our members, 100% said they would be looking forward to offering that quality, affordable health care coverage through an AHP.
Thank you.
I thank the gentleman, and I recognize my friend from Connecticut, Mr. Courtney.
Thank you, Mr. Chairman. And as long as we're all doing homework around here, I just would note that the letter that was submitted from the National Association of Insurance Commissioners that made a forceful argument for retaining state authority over the operation of MIWAs and these association health plans. It was actually a very bipartisan letter. We had the commissioner of the Tennessee Department of Insurance as well as the South Carolina Department of Insurance who signed this letter. And again, I would ask that it be added to the record.
It has been already, and duly noted, and Mr. Mitchell and Mr. Rowe probably want to discuss that with you.
Well, again, I think these are the folks who are closest to this issue on the ground, and they talk about the fact that these plans have been plagued by insolvencies. That's quote unquote in terms of the letter that they submitted. And again, they raised a whole series of questions because frankly the department has been very kind of slippery in terms of just what is going to be the lines of authority here, as was stated by some of the other witnesses. And because of that, they said at a minimum this rule should be put off till 2020. Till we get to a really clear understanding of this. I would just say, to Mr. Condalucci that, the track record of U.S. DOL in terms of enforcing pension problems that again is their jurisdiction since ERISA was passed is very, very spotty. And we've had casework in my office where we have struggled, even under the Obama administration, in terms of getting actually help for people in terms of pensions. So the notion that, not to worry, that the U.S. Department of Labor is going to have jurisdiction over 311 million people in this country with, all the other authorities that they have to do and take it away from the folks in the Attorney General's offices or the Insurance Commissioner's office, in my opinion, is really a very risky proposition. And again, we have ample experience to show that really is not, in my opinion, the way to go, given, again, the real empirical history that we know about in terms of association health plans. Now, we've heard some conversation here about the fact that, we really should give people the option for the catastrophic coverage. Mr. Lewis talked about that earlier. Again, Mr. Arnsauer, I actually just had a hip surgery 8 weeks ago. And, after one night in the hospital, it was, get out of here. And because as we know, healthcare has shifted outside of hospitals now. I mean, the notion that the old days of catastrophic coverage, actually, that was where the majority of healthcare was delivered, back in the 60s and the 70s, in the heyday of catastrophic coverage. The essential health benefits, which was part of the Affordable Care Act, was grounded in the Institute of Medicine going out and analyzing, what is healthcare? Where is it delivered? And that's really what was sort of the structure in terms of making sure that people are going to get the necessary care that they need. And catastrophic plans, which just take care of hospitalization, that doesn't work in the 21st century. And I was wondering if you could comment on that.
Well, absolutely. And I want to echo what the ranking member said, that the way we're going to, first of all, the ACA needs some fixes. I mean, we're the first to argue that. But we need to do this on a common ground, working together, and with a common risk pool, with common rules of the road. And if you start to sort of balkanize or break off different pieces of the market, it makes it much harder. Essential health benefits not only were put in place to cover what was generally perceived among professionals to be stuff that should be covered, it also was a common set of rules. And again, to state again, Mr. Condalucci said the small group market, as a result, doesn't have a lot of price differences in it because of that. So we would absolutely, we want to see more competition. We want to see fixes made to the Affordable Care Act, but we want that done with a common set of rules.
Thank you. And again, as a small employer myself, before I was elected to Congress 10 years ago, and saw what was happening to age rating pre-Affordable Care Act, I mean, every time I had an employee who hit the age of 50, their rates went through the roof because age rating was about 6-to-1 back then under the market. The ACA contracted that down to 3-to-1. And again, I wasn't here earlier, but I just want to reinforce that point. We are opening the door here now to age rating, which I have a lot of realtor friends back home. I mean, they tend to be, folks in their 50s and up, and they tend to be, frankly, more women. And gender rating and age rating, you're reintroducing that. Careful what you ask for. And I would just note again, lastly, that there are 652 operating association health plans in this country right now. So this is not like the ACA posed some existential threat to association health plans. They're out there and they're working. The question is how are they going to be organized? And we want to make sure that people get the care that they need in 21st century terms, not 20th century terms. And we also want to make sure that the benefits are going to be fair in terms of how they're allocated. With that, I yield back.
I thank the gentleman, and now I'm privileged to recognize the gentleman and hero from South Carolina, Mr. Wilson.
And thank you very much, Chairman Tim Walberg. I appreciate your leadership to promote positive health care, to address that Obamacare has destroyed 300,000 small business jobs and forced 10,000 small businesses to close. And Mr. McGraw, thank you for your testimony on behalf of the National Association of Realtors. As a former real estate attorney myself and a grateful dad of a realtor, I appreciate your service on the executive committee and board of directors of the association. You mentioned in your testimony that many of your real estate agents serve as independent contractors. Can you explain the system in the real estate industry and elaborate on the advantages that operating as an independent contractor provides for real estate agents and for the agencies they work?
Thank you, Mr. Congressman. Yes, independent contractors are a notion that not everyone understands. When you have the opportunity to make a living with the least number of restrictions on the way that you do your business, that is the spirit that most independent contractors, certainly realtor independent contractors, bring. They want that opportunity to build their own brand within the confines of the required supervision that companies like mine provide for them, but they can build their own business with a minimum of interference, and that's the good news. The bad news is, as I mentioned in my testimony, it's a eat what you kill business. They have to have something to hunt, and we do not guarantee them a paycheck.
Well, I just want to point out, too, as Mr. Courtney, that we appreciate realtors in our community. They're leaders in the chamber, the Rotary Club, the Lions Club, wherever you need a volunteer, that's a realtor. So thank you very much.
Thank you.
For such professionals. And Ms. Monson, I want to thank you for being here today, too, on behalf of the International Franchise Association. Your organization is appreciated for providing entry-level jobs leading to extraordinary achievement for workers. What a great opportunity you provide for young people in particular to achieve. You mentioned that the recently proposed rule to allow small businesses to band together to help lower costs, create greater flexibility, increase access, and reduce administrative expenses. You noted that many of the same principles have been allowed the franchise model to be successful, having franchising especially suitable to the formation of association health plans. You say, quote, franchising is perfectly built for AHPs. Can you explain how the franchise model utilizes distribution, communication, and business practices that would complement an association health plan?
Yes, thank you very much. So if we take a look at just what Fast Signs International does for its franchisees, with over 600 locations in the United States and then another 30 in Canada and other countries as well, when we look at the supplies that they use every day, we negotiate with vendors because of the volume purchases, we get lower prices. Even for services like payroll processing, we have an amazing rate with some of the payroll processing companies, giving our franchisees lower costs compared to their independent competitors. And we do that with equipment, supply, services, everything that a franchisee in our business would need. We have that expertise. We have a supply chain group that focuses just on lowering costs for franchisees through negotiating. Likewise, the International Franchise Association could do the same, bringing that same knowledge and expertise of franchising, of group buying power and negotiating. And so we're very confident that we can bring the costs down and compete for the same quality coverage that large companies and unions have at a lesser price, using that supply chain negotiating skill and experience.
And again, I appreciate franchises. On Sunday, I was at a Wendy's, and I couldn't believe how hardworking the people were as they were confronted with a baseball tournament at a next-door park, a line as far as you could see, and then a bus full of Chinese tourists in West Columbia, South Carolina. So, and the people behind the counter had a smile the whole time, which was startling. And then, Mr. Condalucci, in your written references to the 2011 guidance by the Department of Health and Human Services prohibiting forming a fully insured large group plan, what impact did this have on association health plans?
I first want to set the record straight that when I said that small group plans typically have uniform prices, that's based on the fact that there's uniform rules within a particular market. But different states, small group markets vary widely, so costs vary widely. And relative to the large group market, small group market costs are much higher. So I just want to set the record straight because Mr. Ahrensmeyer continues to point out the point that I had made earlier. So I just want to clarify that point. Sir, to your question, thank you very much for that. The 2011 guidance had an adverse effect on employer-run organizations like local chambers of commerce and otherwise who are offering fully insured association health plans. It essentially blew up their plan. They had a choice to either discontinue their plan or shift to a self-insured plan because the guidance required the insurance company to look through the association to the underlying size of the group to apply the ACA's new market reforms, and that had an adverse impact and discouraged these employer-run organizations offering these plans. And that is the adverse effect that the 2011 guidance had on those fully insured arrangements.
And thank you all for being here today.
I thank the gentleman. I want to this time thank the panel for your competency, your commitment to presenting your case in the real worlds that you live in. So thank you for taking the time to be with us today. So at this point, I would ask my friend and colleague from Delaware, Ms. Blunt Rochester, for your closing comments.
Thank you, Mr. Chairman. I want to first thank the Chairman and the witnesses for your testimony. Actually, Ms. Monson made a comment about caring about the brand and also about our people, and that is evident by the fact that you are all here on this panel. I think one of the challenges that we face as lawmakers is that, and the same with our attorney generals across the country and our insurance commissioners, is that we're protecting folks because of folks that aren't in this room and that don't care as much as you do, which reminds me of a clarification that we'd like to share on the letter that Mr. Courtney referenced. It wasn't a duplicate. It was actually from the National Association of Insurance Commissioners. So we'd like to submit that letter on his behalf.
Without objection, I hear none. It will be submitted.
Thank you. And I opened this hearing by noting the 8th anniversary of the ACA and just a reminder of the progress that we've made in ensuring that more Americans have access to affordable, comprehensive coverage. This anniversary also serves as a call to action to strengthen the ACA and to do more to increase access to coverage. Instead, it feels like we're again defending the healthcare system, and at the latest, we're now attacking this from the small business owners and their employers' perspectives, their employees. I just want to be clear that I fully support small business owners, both in my home state of Delaware and across the country. Small businesses are the driving force of our economy, and it's critical that we work to ensure that owners have the resources they need to build thriving businesses of their own. That is why I'm deeply concerned about the potential impact of this proposed rule on small businesses and their workers. There is no doubt that the expansion of association health plans as proposed under the rule would needlessly expose hardworking small business owners and their workers to inadequate coverage and out-of-pocket expenses. Many of the over 900 comment letters from legal experts and consumer advocates that were submitted to the department have been mentioned here today, and many of these comments raise concerns that the proposed rule could destabilize the state-regulated individual and small group markets, leaving consumers with less comprehensive coverage, undermining states' authority to regulate health insurance markets and protect consumers, and exposing small businesses and workers to fraud and insolvencies. As you are aware, there are serious doubts as to the Department of Labor's legal authority to make the policy changes envisioned in this proposed rule. Mr. Condalucci, in his testimony, characterized the rule as changes to the law. If we want to help small businesses and their employees, we should not advance a rule that would leave them with insufficient coverage that renders them unable to access vital health services such as mental health treatment, maternity care, and substance use disorder treatment. I do think the committee would benefit from the opportunity to hear from the Department of Labor on this rule, and I will look forward to working with Chairman Wahlberg to make that happen. In the meantime, I think our time would be better spent talking about efforts to strengthen the Affordable Care Act and increase access to affordable, comprehensive health coverage. I yield the remainder of my time.
I thank the gentlelady. And again, this hearing has been just that, a hearing opportunity to have ideas and concerns raised, to give us a better opportunity to address. Yes, 8 years of the Affordable Care Act is coming to fruition. During the course of all of those 8 years since the Affordable Care Act was passed, in a non-bipartisan fashion and pushed through, we've had to deal with it. And multiple times, in fact, we have reformed portions, repealed portions that didn't work in the Affordable Care Act, and have done that to a great degree in a bipartisan fashion, with even President Obama signing some of those changes. We did pass in the House a very significant comprehensive reform, to a great extent a repeal. We did our work on that. We continue to address concerns, and this indeed is one of those areas that we have to work towards. As I listened today to the panel, it just reinforced my memory on the fundamental strength of this country that was developed as a result of small businesses, entrepreneurial efforts, people who took risks to provide goods and services to our developing nation, that brought about a financial system, a finance system that was enabled to assist businesses, small businesses, entrepreneurs, in starting out their life and the opportunity to succeed in this great new-formed country, which had an idea never before tried in the world. And doggone it, we've been pretty successful, haven't we? And I think our process is to continue that and to find means by which we can encourage not simply corporations, and we love that, certainly in Michigan, with the auto industry and many other large corporations that have helped this country be what it is. We still go back to those small businesses, businessmen and women who take that risk and want to move forward, who don't want to be a part of a large corporation necessarily. But I would also state, want to acquire a workforce that makes them successful. And in this day and age, unlike not all that far back, there are communication abilities that allow individuals to know what's working and what will work better for them in another business opportunity. And so the competition has been ramped up. And I think it's a moral obligation for us to be as least restrictive as possible with the basic preventative and protection requirements still put in place, yes, but least restrictive to allow these entities as well, small businesses, to compete on as level of a playing field as we can make it, by allowing them to offer and afford to their employees an equal opportunity to have the most important care that they feel for themselves, and that's health care, brought to them in the least restrictive way, in the fullest possible way. And so that's the purpose of this hearing today. I think the issue will go on. I think we'll continue to discuss it. We certainly want to hear from the Department of Labor. We want to know that they're doing good work to make sure that our people back in our districts have that good work made available to them to continue to advance, to care for their employees, and to do it in the best way possible. So again, I thank you for our committee's efforts. I thank the panel for being here today. But with no further agenda before the subcommittee today, it stands adjourned.